I can't, yeah. All right, so everybody, welcome. It's my absolute pleasure to get to introduce two speakers today. Dr. Yanxun Xu, who's an associate professor, and Joseph and Susan Genichis, faculty scholar in the Department of Applied Math and Science and Statistics at Hopkins. And her research really, her interests lie in developing statistical and machine learning theory and methods for a broad range of problems, such as reinforcement learning, high-dimensional data analysis, non-parametric statistics, and uncertainty quantification. And the methods that she develops the amazing thing is she's at the level of the methods and then applies them to clinically relevant questions and as it relates to electronic health records, dynamic treatment regimens, cancer genomics, early detection of Alzheimer's, mental health in people with HIV, and early phase clinical trial designs. And so we're going to get to hear from her. And she's also part of our brain health program and leads the data science and mathematical modeling team with Dr. Raha Daskeb. And then that will be the first part. And the second part, we get to hear from Eero Korpela. Hopefully I pronounced your name correctly. Awesome. And he is a second-year PhD student in the Department of Applied Math and Statistics at Hopkins. And his research focuses on developing statistical and probabilistic methods with an emphasis on precision medicine and Bayesian statistics. And he's, again, has been taking and creating rigorous theoretical frameworks and computational tools that he's using to tackle complex problems in healthcare, such as optimizing treatment strategies, enhancing diagnostic accuracy, and integrating heterogeneous data sources. And he is one of Yanxun's mentees or PhD students. And so I'm going to hand this over to the two of them. I'm super excited to hear what you have to say.
Hey, thank you, Leah, for your nice introduction. Yeah, so today's talk is we want to focus on two perspectives of HIV treatments. So one is on the ART drug, and another one I will present is a non-ART drug. So I will present on the ART drug part. So we know for routine HIV treatment and monitoring, the patients are typically advised to visit the clinic every 6 months. So during each visit, a lot of information will be collected, such as social demographics and the lab results, and also some clinical factors. And then based on this information, the physician will decide, what's the ART regimen they prescribe. So usually we know it's a combination of ART drugs. So for example, here 2 NRTI drugs and 1 INSTI. So this process repeats every half year. So essentially, prescribing the ART is a sequential decision-making problem. So in general, to determine the optimal sequence of treatment, we know the clinical trials is always a gold standard. However, it's often costly and may not be feasible in many scenarios. So for example, in our case. So luckily for us, there are a lot of data existing, for example, like the MaxWise data we analyzed. So they kind of motivate the development of data-driven clinical decision-making methods. And what is lacking is a robust data science methods that can model the data and help us make accurate and reliable sequential decisions. So for the HIV treatment, we know the US Department of Health and Human Services have already provided a general guideline for prescribing ART treatments. So these guidelines are particularly useful for treatment-naive patients. So they offer very clear recommendation what should be, what should start. However, for heavily pretreated individuals with HIV, many factors must be considered, including a lot of potential adverse effects of long-term ART use, such as depression, weight gain, kidney disease, and also their adverse effects on cognitive impairment. So a lot of side effects. So now there are some tools available to assist in optimizing their ART regimen. So for example, HIV Assist. So probably some of you may know that's developed by our colleague Monarch Shah. So this tool is basically built by a team of ID doctors, and they compile information from the guidelines and also some literatures, and they generate a rule-based scoring system to recommend regimens. So essentially, if you use their tool, you just input like mutations and the variloads and comorbidities and some co-medications, and then they will generate this weighted score for each regimen. However, for a specific patient profile, multiple treatment options may be available. So for example, here, like maybe, like 10 regimens here, they are actually equally good for the patient based on the clinical guidelines. And also, when we face two potential risks or adverse effects, how do we determine like which one to prioritize or compromise on? That's also a problem. And also, this tool does not account for the long-term health outcome for people with HIV. So our goal is to develop like a method that using the data we have already collected, but adopt a data-driven approach to personalize ART regimen in order to optimize the long-term health for people with HIV. Okay, so the data we use is Max-Weiss combined cohort study, and they provide us opportunities to achieve this goal. So they collect data on average, like based on patients' semi-annual visits. Here is an example. So it's a ART treatment history for one randomly selected participant. So you see this participant has 7 visits, and also we have their ART regimen they have been using in the past. And here the x-axis is a calendar dates of the visit, and the y-axis is the number of drugs they used, is ART drugs. And different colors represent different classes. And also at each visit, their health-related environments are recorded. So for example, like depression score by CSD and variloads, CD4 count, EGFR for the kidney function, and also BMI. So all those are recorded at each visit. Of course, we will have missing data, but we have this information across their visits. Okay, so to achieve our goal, there are many challenges. So first, we need to first estimate the ART regimen before we assign them, right? So we need to know their effects from a high-dimensional and unbalanced space. So here, when I say high-dimensional, is that with more than 30 ART drugs on the market, there are a very large number of possible drug combinations. So for example, in the data we analyzed, there are thousands of combinations actually appeared in the data. And also when I say the unbalanced, it means some drug combinations are frequently used, some are not. So for example, for these drug combinations, there are 2 NRTI drug and 1 PI drug. It was recorded almost like 1,000 times in the data. But another very similar drug regimen, like 2 same NRTI drug but different PI drug, it was only recorded 12 times in the data. So how can we handle this unbalanced issue? And another challenge is if you want to assign the regimen, we know that regimen basically is a combination of drugs. So we need to assign a realistic regimen from a large discrete space. So a naive way is like, how can we represent this ART regimen, right? So a naive way would be, okay, let's just use an n-dimensional binary vector. Let's say if we have 30 possible ART drugs, and then we have a 30-dimensional binary vector to represent the regimen. However, this representation will lead to like 2 to the, for example, if you have 30 ART drugs, then you have 2 to the 30 possibilities. However, many of them will never be prescribed in practice. So that's also, it's another challenge. And the last challenge is how can we optimize treatment from the observational data? Because the data we have already collected is not clinical trial data. So there is some challenge called distribution shift in the world of machine learning. And we need to kind of like tackle this challenge when we do the modeling. Okay, so here is our roadmap. So it's a series of work. So we want to achieve precision medicine in HIV, but there's ton of work needed. So the first step is we need to understand the ART effect, and then we need to optimize them. And also we want to incorporate domain knowledge. So for example, like the clinical guidelines and also a lot of papers have been published. So we want to incorporate this domain knowledge when we make the clinical decisions. And then we want to develop some, like our holy grail will be the user-friendly tool that can actually help clinicians in practice. Okay, so the first project we have done is about how to understand the ART effect. And here is our model. So I will skip the technical details, but just show like we developed a novel statistical model that we can actually estimate the treatment effect. So here you can imagine like Yij is for participant I at visit J is some health outcome. For example, it can be depression, it can be cognitive outcomes like domain level or the global level. So we basically kind of model the health outcome as a combination of some non-ART effect, including demographics information, clinical, and also a part of only focus on the ART drug combination effects. So remember I said the drug combination, this regimen space is high dimensional and unbalanced. So that's kind of like our innovative method tackling this problem is we have this HZIJ to model the ART combination effects. And also some other term is like regular noise and some dependence on the outcomes. Okay, so it kind of like the rough idea, but I will skip the technical details. And let me show you the results. So for this model, we can actually do the individualized prediction. So for example, for this participant, she had 6 visits, and we have their age, BMI, CD4 count, viral load, hypertension, substance use, and also the smoking status. So that's their past information. And also we know the regimens this person has used in the past 6 visits. So our tool, using this model, you can actually predict, like for example, like we develop this tool, like on the left side, you can actually input this person historical information, and then you say, okay, maybe I want to use this drug combination. And then we actually give you the predictive. For example, here we use the depression as an outcome of interest. So as long as here you input, okay, here is a drug combination we want to use, and then you can get the predictive depression score. So here we have those like somatic, negative, positive, interpersonal, like kind of like domain level of the depression score from the CESD. And then you can change to different regimens if you want to see, okay, like maybe which regimen leads to the least adverse effects on depression, and then you can try these two. Okay, so that's kind of like our first try of understanding the ART effects first. And after this one, we start to think about, okay, now we understand the ART effects on certain health outcomes. How can we optimize ART? So that's kind of like the second step. So the second step is we have tools to optimize the ART. Okay, so essentially here is approach overview. So we develop a reinforcement learning method. So reinforcement learning basically is a term in machine learning that you can optimize sequential decisions and based on this person involving data. Like here we have drug histories and also their health outcomes. So for this method, it has a 2-step approach. So the first step, we develop a Bayesian dynamics model, and we utilize the data we have. So diagnosis, survey data, lab tests. We have all the data, and we use a Bayesian dynamics model to understand how those health outcomes like change over time. So for example, if it's depression, we want to know how depression evolve over time, conditional like this lab tests and ART treatments. And then the second step, we have a like offline reinforcement learning approach. So we can utilize the uncertainty learned from these longitudinal trajectories and then optimize the treatment. Okay, so here just an overview. And then here I will show you some results. So for example, here is one participant. So this person has a lot of visits. So this person has like 31 visits. And here we also show the ART regimen they used. And our method can actually, these reinforcement learning methods, as long as you define what's a reward. So here, for example, here we consider reward to be a combination of viral load, CD4 count, CSD score, EGFR, FIB4, that's for liver function, and also cognitive scores. So it's kind of like we define a certain reward to represent the long-term health for people with HIV. And then we estimate the optimal regimen that can optimize, kind of like maximize the reward. And here would be the recommended regimen for this person in the next 2 years or like next 4 visits based on the semi-annual visits. So these methods we can also kind of like interpret. So like we also have some interpretable results. Like for example, when we assign these treatment regimens, and we actually know, for example, like which factor plays an important role. So for example, for this specific person, and our method tells us, the depression actually kind of like plays a very important role when we decide the optimal regimen. So we also kind of like we predict the depression score under the estimated optimal regimen. So here we can see this person is highly depressed. Like the CSD score is way larger than 16 at like visit 30. And then if they use the recommended regimen, and the depression score would like kind of reduce to some like around 30. So that would be a 23% of improvement for depression if you use the recommended score. Okay, so that's for the optimizing ART part. However, after we developed the tool and we figure out it's too slow, because it's a very sophisticated method, it takes like 20 minutes just to run for a person's optimal regimen, and we figure out it will not be realistic in clinical practice because no one wants to wait like half hour to just get the results. So we want to say, okay, maybe there are any faster way, that can actually be used in clinical practice. So this is kind of like one follow-up work. We developed a tool we call HIV AI Care. So it's based on the model-free reinforcement learning methods. So we still use the data. It's the same as, like the MaxWise, all the data we have. And then we have it's like the machine learning, a deep learning tool. It's based on the transformers. So for this tool, it can be very useful for the sequential decision making because we can actually take into account the whole history of this person's ART regimen and also the past historical information about like lab tests, like very low the CD4 count, all those information. So again, it's like the deep learning methods. And then based on these methods, and then when a new patient came in, and we will try to optimize the regimen. Okay, so let me show you some preliminary results. So here is one participant. So this tool can actually give you, for example, the ranking of the ART regimen. So here I list the top 5 ART regimen by the AI policy. Here the red part is the regimen that actually assigned by clinician in practice. All the people self-reported from the MaxWise. So we can see the actual regimen this person took is ranked number 2. So and then we start to dig in why we rank this regimen RL plus DRV plus RTV as the top one compared to the regimen this person actually taking. So we dig in those health outcomes. And for this person, we found out, for example, the depression score is very high across the time. So you see it's always larger than 16. And then we plot the Q values. So here the Q value is a concept of the reward, like the health outcome. So you can think about these Q values, the larger the better. So that means if you have a larger Q value, then you have better health outcomes, like lower depression score and higher cognitive outcomes and normal kidney function and normal, liver functions. So we plot the Q value versus the depression score. So we can see here for the person, like the person actually took this drug regimen, the blue line. So we can see when the depression score is smaller here, the Q score actually is high. However, when this person mental health gets worse, like depression score gets larger, our recommended one actually has higher Q score. So that means in the clinical practice, it's possible, one plausible reason is like when the clinician assigned this drug regimen, they didn't really take into account the mental health situation. However, for this person, if you have high depression score, so if you change this drug regimen, you actually have better outcomes in terms of mental health. So that's one example. And here is another example. So that's another participant. Again, we see the regimen this person actually took is this regimen. And then we recommend this regimen. So again, we plot and we found out the EGFR actually plays some role, like for this person, like the EGFR, we can see always like this EFV plus TDF plus FTC gets like better kidney function prediction. Yeah, so I think when you see these results, you may be wondering, because MVC actually usually is affiliated to a specific genetics information, right? So when clinician prescribe this regimen, it's usually because the specific genetic profile, and also the EFV now, to be honest, is not really popular because there are psychiatric side effects. So I think that's kind of like also motivates us to think about what's lacking from the current method, because the current method is totally data driven. And if you think about the data, it can be biased, right? So for example, if people no longer assign the EFV for the people with HIV, and then if the people with better mental health, you can use the EFV, but if you have mental health concerns, you're not going to assign the EFV, then the data is kind of like you will see people who took the EFV means they have better mental health outcome. So that's also similar for example, the drug ABC, for the people with cardiovascular disease, and the clinician will avoid this drug. And then in the data, you will say, okay, for the people who have taken the ABC means they don't have any problem with cardiovascular concerns. So that's kind of motivate our next step is we want to incorporate the domain knowledge. So here, when I see the domain knowledge, it means we have a lot of information we need to take into account into the model. So for example, we have the treatment guidelines. They give us a lot of detailed instruction. If this person have kidney problems or liver problem or bone problems, what kind of drugs we should avoid, and also a lot of literature on the common side effects of HIV medications, and also for example like Stanford the HIV drug resistance database, like we have the the genetics information, like if you have these mutations and what potential ART drug, what ART drugs could have potential interactions. And also some other tools like drug interaction checker, it's kind of like related to, what Arrow will present, there will be interaction between the ART drug and non-ART drugs. So there are a lot of this domain knowledge we want to incorporate into our model. So our first thought is we can use the, large language model. So for example, the ChatGPT-4. So if you input the information, for example, like suppose you are an HIV physician, and you have a patient whose very load is like 10,000, BMI is 22, and has diabetes. What's the top 5 ART regimens would you recommend? And we found out the ChatGPT-4, because they use a lot of online information to train the model. So it's kind of like some word makes sense, but it's not perfect, because they just kind of like get some very general information from the guideline. They didn't really consider this person like specific information. So it's okay, but it's not good enough. So what we're doing now is like we're combining the large language model with the reinforcement learning method we developed. Because the reinforcement learning method we developed, I just presented the results. It's kind of like only based on the data we observed, but it didn't have the domain knowledge. So our solution is we want to incorporate the large language model, use all those domain knowledge as it's kind of like we fine tune the large language model based on all those documents. So for example, now we have already fine-tune the large language model by inputting, the treatment guidelines, and also thousands of papers, and also the Stanford database, and also the interaction checker. So we have all those information, and we input them to the large language model and fine-tune the large language model, and then combine with our reinforcement learning. So it will give us more reasonable, or like the regimen that makes more sense in clinical practice. And also there are some things we want to consider in the future is about like human feedback, because we know in clinical practice, the clinician also like, after we give recommendations, they will also have some inputs. So it's kind of like we want to have some methods that can actually incorporate the clinician's input to like, improve the model. So it's kind of like after we develop the tool, and then we have those, like the model and give you the recommendation, but the recommendation actually, we want the clinician's input. So, and then they will say, okay, I will adopt your recommended regimen, or I have other concerns, I will choose another regimen. So it's kind of like we want to have this like evolving tool, like once we have more data and the model can actually be improved. Okay, so that's kind of like the thing we're currently working on. And we have a tool, but it's not online yet because we feel like it's still many things to kind of like finish before this can be actually helpful in clinical practice. So we are still developing, but it's just prototype. And also there are many other things to consider for further development. So for example, we want to incorporate the non-ART drugs. So that's Arrow now is working on. And also the cost of the, the regimen, and also the, people's insurance status, and also regional availability. For example, some drugs available in the United States, but not in like Uganda. So we will need to take into account all those in our decision making too. Okay, so that's all. So I want to thank all my collaborators, Leah Raha here, and my students, and also my collaborators in other universities, like so Professor Yanni, so he's working on more like statistical methodology, and Amanda, Jane, and Luis, they're clinicians and help a lot along this development too, and also all the participants in the MaxWise and the funding. Yeah.
Thank you, Yanshun. That was awesome. There are a ton of questions for you, but let's try to wait for questions if possible at the end so that Arrow has enough time, if that's okay.
Yeah, sure.
Yeah, and then, but you can take a look and then address some of them in the meantime, and then we can come back around after Arrow speaks.
Yeah, sure. I'm reading the comments. Yeah.
All yours, Arrow.
Hi, perfect. So hello everyone. Today I will present on some research I've been doing with Dr. Xu and members of the BHP group, specifically on the longitudinal effects of polypharmacy on cognitive function in people with HIV. So polypharmacy, commonly defined as the concomitant use of 5 or more medications, is a growing concern in clinical and public health context due to its association with adverse health outcomes. Recent studies estimate that 37% of individuals aged 19 and older experience polypharmacy, with an even higher prevalence observed in older adults where chronic comorbidities often necessitate complex medication regimens. Specifically, polypharmacy is prevalent in that it causes 4 hospitalizations per 1,000 people each year, serious in that it's among the top 10 causes of death, and expensive in that it's associated with annual costs estimated at around $30 to $180 billion. Polypharmacy is typically seen as an issue in aging populations, but is also highly prevalent among people with HIV. In people with HIV, polypharmacy usually begins at younger ages due to HIV-related factors and comorbidities such as diabetes, hypertension, and depression. This is also a problem for virally suppressed people with HIV as well, in that persistent immune activation and inflammation contribute to higher prevalence of non-AIDS related complications, necessitating prolonged and extensive medication regimens for virally suppressed people with HIV. The consequences of this extensive medication use are several-fold, including physical frailty, emotional distress, and notably cognitive decline. Despite HAART's effectiveness, cognitive impairment remains a major challenge. The lack of effective treatments for HIV-associated cognitive impairment makes prevention and early intervention critical. To aid in developing strategies to protect cognitive health and improve long-term outcomes, there's a need to determine how polypharmacy contributes to cognitive decline. Previous studies have shown that polypharmacy is linked to declines in cognition, specifically in global function, learning, memory, and verbal fluency. However, most studies in the literature are cross-sectional, offering only a snapshot of associations. So cross-sectional designs do not capture the dynamic nature of cognition changing over time. With that being said, here's a study overview. To start, the objective was to investigate longitudinal trajectories of cognitive function in people with HIV across varying levels of polypharmacy. We define these levels as low being 0 to 4 medications, moderate 5 to 9, and severe as greater than or equal to 10 medications. And this is consistent with previous definitions in the literature. The cognitive tests or domains that we analyzed were global cognitive function and domain-specific trajectories, including executive function, processing speed, verbal fluency, and so on. The hypotheses we had were that polypharmacy broadly impacts cognitive decline independent of medical and psychiatric comorbidities. And the overall goal was that by examining longitudinal trajectories, we sought to identify the cognitive domains most affected by polypharmacy in people with HIV, providing insights that could inform interventions to mitigate cognitive decline in this growing population. So the data sources included were from 3 different studies: Charter, NNTC, and HNRC. The data was collected from January 1999 to March 2020. On the right, we can see some summary statistics of the data that was included in the study. Now, since this is a study on polypharmacy, the first step was to look into the non-ART drugs actually included in the data. Unfortunately, the names of the non-ART drugs in the data set were not uniform, but rather they contained spelling mistakes, different formatting, brand name drugs, combination drugs, and so on. To remedy this, RxNorm's API was used to automatically generate standardized drug names to be used as the start of an ingredient level mapping. So polypharmacy in this study is defined at the ingredient level rather than a combination drug level. More specifically, drug name strings in the dataset were mapped to RxNorm defined drug ingredients using RxNorm API's get approximate match function, and manual verification was performed to ensure accuracy. However, drugs not found in the RxNorm database were fed into a large language model, in this case Gemini, to extract a generic drug name or combination drug name, and then fed back into RxNorm to standardize the name. So for example, this drug diazide, once we feed into RxNorm, it spits out 3 different possibilities. This is maybe not the best example because let's say diazide had a spelling mistake, RxNorm might output like 20 different possible matches. And in that case, it's a little bit difficult to figure out what exactly that maps to. In that case, since no single match was found, we feed that into a large language model, prompting it to give generic ingredients. And then we feed that back into RxNorm to verify that the large language model actually, like the output of the large language model makes sense. So here's a concert plot of the studied cohort. We started with around 26,000 individual data points. And after excluding data based off of population characteristics and missing covariate data, and also missing cognition test data, we are left with around 8,400 data points. And then out of those 8,400 data points, we have 2,173 unique people with HIV and 1,017 virally suppressed people with HIV. So as the first step, since the data is longitudinal, the initial model we fit and analyzed was a simple linear mixed effect model with primary predictors, degree of polypharmacy, and time defined naturally as time since first visit for each person. The covariates used in the model can be separated into 5 groups, including demographic, depressive symptoms, substance use, comorbidity index, and HIV-related variables. The reason why we used VAX was to isolate the polypharmacy drug effect from the effect of underlying conditions a person may have. So the initial model results, so the primary longitudinal results of the study were these longitudinal trajectories of people on low, moderate, or high degrees of polypharmacy. However, this plot is misleading and interpreting the results aren't intuitive. These lines do not really represent trajectories on stable regimens, but rather instantaneous estimated cognitive scores at various time points. So for example, when you see an estimated global cognition score for low polypharmacy at time equaling 10 being around 48, the value is calculated by averaging across all the other effects of all other covariates in the model. And since not all people in the data are stably on one and only one regimen, this means that the line in the plot doesn't necessarily trace the trajectory of a person who remains on stable low regimen over time. Instead, it shows the instantaneous predictive cognitive score for someone in low polypharmacy group at that time based on the entire sample's covariate distribution. This distinction is important because it highlights that this plot is not depicting the true longitudinal trajectories of individuals on stable regimens. Rather, it represents cross-sectional snapshots at each time point for each polypharmacy group. The reason for this caveat is that not all people in the data have complete stable regimens. Here we can see 2 participants' regimens trajectories within the data. Specifically, out of the 2,173 included people with HIV, we have 1,583 people with completely stable regimens and 590 people with unstable regimens. From these 1,583 people, we have a total of around 4,000 visits of data. And from the 590 people with HIV, we have around 4,000 also visits. So it's split basically in half for both. Because the results of the initial model do not answer the questions we really want answers to, we had to come up with a new model that captures the longitudinal trajectories of people on stable regimens and also people with transitions. To do this, our new model replaces degree of polypharmacy with transition as the primary predictor. In this case, the stable quote-unquote transitions, LL, MM, and HH, really represent the same predictors of low, moderate, and high in the previous model. And on the other hand, we also capture all the other possible transitions in the data, such as low to high or low to moderate and so on. Now, since we have unstable regimens, we have to redefine time to both capture duration on a current regimen and time before transition. Thus, we define a new time variable as time on previous regimen. This can be understood best with an example. Here we see the possible data for a participant in the data set with the corresponding degree of polypharmacy labels at various time points and the time between visits. Now, time on a previous regimen for stable periods, i.e. from baseline to 1 year, really represents duration on current regimen. When we get to the first transition at 2.5 years, this person was on low for 2.5 years before transitioning. The value here is 2.5. Note, we make the assumption that a person transitions degree of polypharmacy levels the day they come into a visit. This assumption is made because we have no idea where between 1 and 2.5 years a person actually transitions from low to high polypharmacy. Continuing, now that they have transitioned to high, they have only been on high for 0.5 years when we get the high-high transition or stable transitions remaining on high. And finally, the high to low transition time on previous regimen value is 2.5 because having transitioned to high after 2.5 years, they remain on high for an additional 0.5 plus 2 years before transitioning back to low. Here you can see the estimated main fixed effects for stable transitions. As you can see, moderate and high degrees of polypharmacy have a significant negative effect on cognition across several domains as compared to low polypharmacy. Moreover, the estimated effect of high polypharmacy is greater in magnitude as compared to moderate and low polypharmacy, which aligns with previous work in the literature. Here are the longitudinal results for stable regimens for people with HIV. The lines here represent the estimated trajectories on either low, moderate, and high degrees of polypharmacy, with time being time on previous regimen. Note, this can be really interpreted as duration on a stable regimen. For example, for attention and working memory, people who stay on low see an overall improvement in cognition over time, while people who are on high do not, and in fact see a drop in attention and working memory over time. For other cognitive domains, we see similar results. Here are the longitudinal results for stable regimens for virally suppressed people with HIV. These results align with those in the overall sample, in that we see improvement on low regimen and a decline on moderate and high. Next, I want to discuss the transition effects on cognition. So because this model accounts for people on unstable regimens, starting with the example of transitioning from low to high at various time points of 0, 1, and 2 years for global transition, global cognition. This black dot represents the cognitive level of a person who is stably on low polypharmacy. See how the cognition remains unchanged over the course of 2 years. Now consider the acute effect for a person who immediately transitions from low to high. See how there's a drop in cognition of around 1 point. Now consider the trajectory of a person who stays on low for 1 year before transition to high. Here's the trajectory of such a person. Finally, consider a person who stays on low polypharmacy for 2 years before transitioning. Here's that trajectory. For that person, the drop in cognition is almost 2 points at the time of transition. With that example out of the way, we can interpret this plot better. Here are all the transition trajectories across all tested cognitive domains for comparing low to transitioning from low. We see a similar result where there's a drop in cognition when transitioning from low to high and also from low to moderate. Note that some of these transitions are in the opposite direction, but the results have a non-significant difference as compared to the stable low estimated marginal mean. This is likely the result of low sample sizes for each of these specific transitions, which results in more variable and more difficult to estimate transition effects. And here are the results from transitioning from stable, moderate polypharmacy to low or high. Take, for example, motor skills, cognitive domain, where we see a significant positive effect of transitioning from moderate to low. This aligns with our intuition that deprescribing should have a benefit on cognition over time. Finally, we have the transition trajectories of transitioning from high polypharmacy to low or moderate. Unfortunately, these results are non-significant across the board, so we can't draw many conclusions from this. Again, this is likely the result of small sample sizes for the specific transitions. For example, there are only 34 total high to low transitions in the data. So we've seen how moderate and high polypharmacy is linked with diminished trajectories as compared with low polypharmacy. For lower polypharmacy groups, these people may show stabilization or slight improvement in cognition, while people on moderate to high polypharmacy show no cognitive improvement, in fact, some decline, indicating reduced neural resilience. Even for virally suppressed people with HIV, these people experience adverse cognitive effects, suggesting viral suppression alone isn't protective. For unstable regimens, the findings echo our intuition that transitions where there's an increase in medications results in cognitive decline, and transitions where there is a decrease in medications results in cognitive improvement. A possible limitation of the study is that non-ART medication was self-reported, which again may introduce bias. Also, despite our efforts to control for comorbidities using several covariates, including the VAX index, it remains challenging to determine whether the observed effects are due to medications themselves or underlying health conditions. Despite these limitations, our findings support the need for refined polypharmacy management strategies to mitigate long-term cognitive risks in people with HIV. And thank you.
Thank you, Arrow. So there are tons of questions that are coming in. Hope that means, people are excited about, and interested in this line of work. And this is also stuff that we work on with Ching Ma and the UCSD group, Ron, Ellis, and Scott and group, because a lot of this integrates charter data as well. I don't know if you want to start from the top, how you want to tackle this.
Maybe we can
Scott,
start from Arrow, like Arrow just finished, so.
Okay, anybody want to open up for Arrow?
I have a comment. Hi,
Hi.
everybody. It's Jules Levin. So my comment and question is, I'm familiar with, deprescribing and polypharmacy associated with cognitive impairment and, falls and fractures. This is, we've known this for several years. My concern is this: as an older person with HIV myself, in his 70s right now, I'm on multiple, polypharmacy, probably more than 10 drugs, with my ARTs, over 10 probably. The problem is that so many of these drugs are critical to my health and dealing with managing comorbidities. So eliminating drugs is extremely difficult for many older people. And it's very difficult, I think, for clinicians and patients to make a decision, should any of these drugs be eliminated? And I think that's part of the problem with deprescribing and polypharmacy. Maybe you have comments on that.
Yeah, I think so. So first, I think Ra also asked question on the chat, like, it's essential to control for the underlying conditions, sometimes not the actual medications. So I think first, Arrow actually also working on, whether we can actually infer the underlying conditions from the medication they're using, and then, kind of like use that as, like what's the effect of those conditions on the cognitive outcomes. And then if we adjust for these conditions, what's actually the medication itself effect on the conditions. So that's for first thing. And the second thing, I don't think we're trying to like suggest the prescribing for the non-ART drug, because that's what clinicians decide, right? So if person has hypertension, you need to take the antidepressant drugs. I think here the study, what we focus on more is like, based on those co-medications, like non-ART drugs this person is taking, and then based on the domain knowledge, what's the possible ART regimen this person can take? So possibly, let's say maybe there are 5 different choices. So we want to say if, there are these 5 possible choices, the 5 possible ART choices for this person, and then want to say, among those 5 possible choices, and what's the best one, or we rank them, lead to the better long-term health outcome. So I think that's kind of a goal. We're not trying to control the non-ART part. We're trying to see what's the optimal ART part given this person taking these non-ART drugs.
And Arrow, my comment applies to your presentation. Do you have any comments?
I mean, yeah, I don't think the point of the presentation is to say that we have to deprescribe. That's a decision to be made with the clinician and the person. I think it's more so to kind of discuss these effects over time, because we have cross-sectional evidence, but we don't really have longitudinal effects. So it's more so to kind of look at the longitudinal effects of polypharmacy over time. And again, yeah, it is difficult to kind of control for the comorbidities, as you said, or the drug effect. So that's sort of the work that we're trying to do next. Is from medications inferring comorbidities.
Eero, is
Mhm.
there any way you could do a causal pathway analysis to try and dissect, meds versus the comorbidities for which they're prescribed?
Yeah, Shun, you've developed some novel methods in the causal modeling, whether that would be useful.
So yeah, Ira and I, we discussed this. So what we're thinking right now, so it's kind of still ongoing. We don't have a solution right now. But what we're thinking is like we first infer the underlying condition from the medication first. And then so think about the simple regression model, we will include the underlying condition we inferred from the medication data as well as the medication. So it's kind of like you can think about after we adjust both of them, it's kind of like we learn the condition effects and also the medication effects given the conditions. I think that's what we're kind of like we're thinking the next step. Yeah.
And we also have the data that we do collect here provides the drugs, the non-ART drugs that people are taking and what that underlying condition is. So we do have some kind of data sets that can be used from a modeling and validation. Scott?
Yeah, first of all, I just want to add my voice to everyone else's. What a great job both Dr. Porpola and Shu have done here, and it's highly complex data. And every time you get to a certain level with it, there's another level. What about this? What about that? And I was engaging in a little bit of that myself. But I'm speaking up just to ask Ron and others. I wonder if we've Eero and Yanshun and Leah and ourselves, we've all been tried different approaches to accounting for the influence of the condition for which the drug was indicated, but there's a lot of heterogeneity, and there's this issue that I've brought up about drug development and prescribing practices over calendar time, right? And it applies both to antiretrovirals, but to every other field of medicine, right? There have been GLP-1 receptor agonists didn't exist, right? And so it looks like I accidentally raised my hand again. But the point I want to make is I wonder whether another approach to dealing with that is to take a condition like hypertension, like depression, and look at the drugs prescribed within people with that condition, with the question being, if you have depression, if you have hypertension, does it matter which drug you get? If you have HIV and you're on these ART drugs, and it's going to reduce the sample size, but I think I think in many cases we won't get a good answer, but in some cases we may. And that might be a better approach, sort of a stratified analysis rather than trying to lump, cardiovascular risk conditions together or psychiatric mental health conditions together, because they're so diverse. Anyway, it seems, as I say, it seems self-evident. There's strengths and weaknesses with that approach as opposed to another approach, but I'm curious what others think.
Yeah, I think maybe I can chime in a little bit. So I think that's a very good question. So at the beginning, we also thought about we just focus on one condition because that would be easier. But like Scott, you mentioned, we have a small sample size. So if we only just focus on one, and then you will have very small sample size, and also this person could have also other comorbidities. It's kind of like we have to borrow some information because most people, they have multiple comorbidities. So I think the kind of like the machine learning or AI method we're thinking now is like maybe we kind of like we need to define some pattern, and this pattern is more like for example, those people have the comorbidities of hypertension, diabetes, and those group people have hypertension and kidney disease liquidity. For example, it's kind of like, I think I want to define some type of pattern, but what's the definition of this pattern? I don't know yet. So it's kind of like we want some model, we can define certain pattern of the combativities, and then we can do the clustering like Raha have done. You know, we do the cluster of the cognitive trajectories, and then we link those, you know, cluster of the cognitive trajectories with these patterns. So I think it's kind of like somehow also address the question of like heterogeneity you mentioned, because, you know, the data definitely is very heterogeneous. So it's definitely clusters. It's just like how we find these clusters, how we link those like cognitive clusters, cognition clusters, and the condition clusters, all the cluster based on the medications. It's like how to link them. Also, it's, I would say it's a methodology challenge. Yeah.
Thank you. I just want to repeat how I think valuable these analyses are to the field. So thank you both again for moving them forward.
And
Thank
just
you.
to kind of comment where Yan-Chun started, right? It's initially finding subgroups and looking at how individual antiretroviral drugs influence these kind of brain health outcomes. Then it was, you know, integrase inhibitors, switching, how does that help? Then it was developing methods to kind of look at combinations. So there's been, as I don't know whether it was Scott or Ron, but this is like building blocks, because this is some of the more complex questions that they're dealing with. The nice part for those Scott and Ron and Raha and Yan-Chun and folks that are involved in this more MyAD initiative, which is data harmonization, clustering, and doing machine learning, all of this stuff that Arrow's doing, right? It will be done across all of the databases. And so that will also kind of, I think, help a little bit, Scott. Probably add more. Anyway, any other questions? Oh yes, Dr. Riggs has definitely been on our calls and has been helping out as well. Any other questions for Arrow or Yan-Chun?
Yeah, I see the question about the dosage. Yeah, I think that's we actually, I think Donna sent us the data of the dosage. So Arrow, I think you check the data. There's only a small portion of the data they actually have dosage. Yeah, but we are trying to use, because like we know for the non-ART drug, you know, the different dosages may indicate different underlying conditions. So we have this information. We definitely want to use it for the model.
Did we end on time? Any other questions? Again, Yan-Chun and Arrow, amazing job. Again, just such a complex aspect of, you know, an area that needs a lot of focus on in HIV. I think next week we don't have a meeting. Most folks will be at Croy. And then I think we pick back up the following. Is that? Caroline,
yeah, we pick
you
up
know?
on the 19th, and it's Laura Cheney from Albert Einstein is speaking.
Perfect. Awesome. So for those of you traveling, safe travels. We look forward to seeing everybody, I guess, back here in 2 weeks. And again, Yan-Chun and Arrow, amazing job.
Yeah, thank you for all your questions.
Yeah,
Very inspiring.
Yeah.
Yeah. Okay, thank you. Bye.
Bye, guys.